I'm going to talk about the injury patterns in a 44-year-old male CrossFit athlete who's a little bit mesomorphic in body type. He presented with right-sided calf muscular tendinous junction strain, generalized left hip pain, lower lumbar back pain on the left around quadratus lumborum and erector spinae, and pain around the posterior aspect of his shoulders around serratus posterior superior and levator scapulae. So as you can see, we've got a longer left leg with a sacral base obliquity high on the left. This was a bony difference. His feet are fairly unremarkable with a little bit of forefoot equinus, an average subtalar joint axis, and in stance the left foot was fairly neutral and the rear foot vertical, but on the right side it was slightly inverted. So looking at him on the treadmill at 4 kilometers an hour, you can see the longer left leg. But the thing I want to point out at this stage is the strength around his lumbar spine. That's longissimus thoracis and iliocostalis lumborum. Now, although he may have hypertone and quadratus lumborum in the multifidi on the left, you wouldn't see it from this view because they're deeper muscles. So let's take a closer look at the lower back. The sacral base has an obliquity high on the left, and the lumbar spine is very straight. Therefore, the functional scoliosis has to occur higher up in the thoracic spine. So note that the right arm is further away from his body. Because his centre of mass is dropping down to the right, his arm can actually contribute to his drift of his centre of mass in that direction. This view shows the functional scoliosis in the thoracic spine, partly created because he can't create the scoliosis further down because of the strength in the lumbar musculature, and partly because of an issue with his posterior oblique sling that runs from left upper to right lower. This is created by the longer left leg. So if we look at the injury pattern marked in red, from right lower to left upper, it runs along the line of the posterior oblique sling marked in green. So let's take a look at pelvic adaption because of the longer left leg. On his left side he has 4 degrees positive, which means he's got a PI ilium, that is a posterior rotation. But on the right side he has a naas ilium, which is an anterior rotation of 14 degrees positive, giving him an overall pelvic torsion of 10 degrees. So when we talk about pelvic adaption for leg length inequality, we're talking about the relationship between the sacral axes and the acetabular axes. The greater the distance between them, the greater the rotational lever arm. The smaller the distance between them, the shorter the rotational lever arm. And it's the lever arm that either pushes the pelvis backwards in a PI orientation or forwards in an AS ilium orientation. So with the PI ilium posterior rotation on the longer leg side, forces build within the acetabulum that creates a posterior rotational lever arm on that side. This can keep the aneurysm in a posterior orientation for long windows of time, either creating or contributing to repetitive injuries. So if we take a look at his AS ilium or anterior rotation on his right side, which raises and externally rotates the acetabulum, this is an adaptation to the short leg and creates an anterior rotational lever arm. Now from experience, an anterior rotational lever arm is generally shorter than a posterior rotational lever arm. So why would one individual create a posterior rotational lever arm on a longer leg and another individual create an anterior rotational lever arm on a short leg? Well, sometimes they occur concurrently on each side, and sometimes you'll have a dominant adaptation. So someone might be all posteriorly rotated on a longer leg and another individual might be all anteriorly rotated on a short leg. This depends on the starting point of the sacrum. If the sacrum is naturally flexed or more flexed than normal, you're more likely to develop an anterior rotational lever arm and an AS ilium anterior rotation on the short side. If your sacrum is less flexed or slightly counternutated, extended, you're more likely to develop a posterior rotational lever arm and all the adaptation will be on that side. So let's look at some of the vertical ground reaction forces on a pressure plate. As you can see, there's more weight on the lateral side of the right foot as the centre of pressure is pushed over to the right side from the longer left leg. The centre of pressure moves forward slightly faster on the right, creating an increased time pressure integral on the right forefoot. The right heel lifts early, creating the pressure at the muscular tendinous junction on the right calf. This is one of the very clever adaptations to create vestibular balance and establish what I call the essential T, which is a horizontal line that runs through the eyes and a vertical line that runs down to the centre of mass. The other fascinating feature that I want to point out with this particular client, due to the orientation of his subtalar joint axis, is the way that the PI ilium pushes the centre of pressure trajectory in a medial and forwards direction, as you can see from the red arrow. This has had a similar and fascinating effect on the right side because of the AS ilium, in that the centre of pressure is now being pushed laterally but in the same direction over to the right because of the drift of the centre of mass. So to manage this problem, we recommended bespoke orthoses made on the same day in the Sub4 lab. They had 3 degrees of rear foot varus on the left and 0 degrees on the right. A 4mm heel raise on the right with 2mm extended into the forefoot, and pour on memory foam underneath the polypropylene shell of both orthotics to decelerate the pronation. So the key message from this video is to try and understand the relationship between the injury patterns that occur in the posture. Not all the time do the injuries occur on one side of the body, but they often occur obliquely. This is because of the relationship between the myofascia and the oblique slings, the anterior and posterior oblique slings, which are really important for you to understand the functional anatomy behind. Now, it isn't just functional anatomy knowledge that you need, but dysfunctional anatomy. How do structures react when there's asymmetry? How do they react when one segment of the body is injured? The other key bit of advice I can give you is try and understand the nerve innervations to those injured structures. Because of leg length inequality and the way that the pelvis often sits oblique and with some pelvic torsion, the vertebrae and the discs cannot nicely sit stacked one on top of the other. So there has to be some neural involvement in some way. So to understand the true origin of injury throughout the whole kinetic chain and the relationship between those structures is good functional anatomy knowledge.